Dr. Amy Beck, to my left, is an assistant clinical professor of pediatrics at UCSF and San Francisco General Hospital, as well as co-director of the Healthy Lifestyles Clinic. Dr. Beck did her MD and MPH from the University of Connecticut, after which she did her pediatric residency and chief residency here at UCSF. Dr. Beck's research focuses on the primary prevention of obesity in low-income Latino children and novel interventions for obesity treatment. To her left is Dr. Sarah Kim, who is an assistant clinical professor in endocrinology, diabetes, and metabolism at UCSF. In addition to co-directing the Healthy Lifestyles Clinic with Dr. Beck, she directs the Diabetes Center for High-Risk Populations and the Adult Weight Management Clinic. Dr. Kim's research interests include the management of obesity and diabetes in the safety net population. Finally, to her left is Pauline Grissom, a registered dietitian who has worked as a pediatric nutritionist for 4 years. She is currently the nutritionist for the Healthy Lifestyles Clinic. She received her BA from San Francisco State University and a Master of Sciences in Nutrition and Dietetics from the State University of New York. Her interests are in chronic disease prevention and early implementation of healthy eating habits in youth. So to get started, it would be great if you could just tell us a little bit about the clinic and how you work together as a team.
Hi, so nice to be here. Our clinic is focused on treating kids who are overweight and obese, although the vast majority of patients who come to us tend to be more of the obese to severely obese, so BMIs from the 95th to the 99th percentile and beyond. And currently we offer essentially two approaches to managing our patients. So one is individual visits, so all patients start with an intake visit with us, which the bulk of the visit, time spent in the visit is actually parents are by themselves filling out a very, very lengthy survey about the child's health, about their eating patterns, about their physical activity, parents' perceptions of the child's obesity. We screen for a number of obesity comorbidities, and then they meet with one of the clinicians to kind of establish what's going on with the family, what's going on with the child, screen for comorbidities with laboratory assessment and additional physical exams necessary, and then some goal setting to focus on kind of what can they do as first steps in terms of addressing the child's obesity. And so then we kind of determine from that point how closely we need to follow the child based on their risk and their various comorbidities. And in addition to the individual model, we offer a group education sessions for parents. And so this is a 5-session curriculum, and we invite all children who come to our clinic who are between the ages of 4 and 12 to participate in the sessions. And so they kind of enter in a rolling fashion. So they don't need to start on class 1, they can start on class 5, class 4, whatever, and then just continue through the curriculum. And the way it works is that they come often for a brief visit before, and then they have the group education where we start off all together doing a warm-up, and then we actually have a physical activity program for the kids, and the parents stay together as a group for education on nutrition, physical activity, and also parenting topics related to promotion of physical activity and nutrition. So that intervention is something we really try to push for our school-age children. For our teenagers and the younger ones, then we just try to follow them as closely as possible. And we incorporate our nutritionists and in our own kind of care, and kind of we sort of alternate depending on the family's needs as they come back for visits. So.
I'll just add, for the teens, we do one-on-one visits primarily, and we do manage type 2 diabetes in adolescents in the clinic as well.
Great. What is the scientific evidence base behind your educational approach with patients?
So you're referring to the group education specifically? So there are several studies out there that have found that group educational interventions can be effective at either stabilizing BMI or at least, reducing BMI Z-score, which is a way to, compare kids to each other, and it's a little bit more fine-grained than the percentiles. Many of these interventions that have been published are significantly more intensive than what we offer, but I think unfortunately a lot of the interventions that are in the literature are not necessarily feasible or sustainable for most patient populations. But so essentially we have taken what's in the literature and tried to adapt it to the needs of our patients. But there are a number of studies, and they've been set up in different ways. In some of the studies it was parent-only education, and other studies it's parents together with kids. There are a range of models, and I think there's also evidence for the one-on-one visits and the individual approach, combining medical practitioners and dietitians working together. It does seem to work if people come back and if people persist. And certainly more intensity is better, but we do have a population that it is very challenging for people. And I think really for anyone to say, and now your child is going to come to 16 weekly sessions for the, it's difficult. So we're trying to kind of strike a balance by basing what we're doing on what's published, but also making it feasible.
I'd love to hear about how you make that feasible, and what sort of incentives or motivations you can offer to patients who might struggle to make it to all those classes.
Yeah. So the first thing that we do is we make our clinic is in the evening. Often the parents of the children that we see, they work full time. They work two jobs. They often work in the evenings until the evening. They don't have things like sick days and things like that. And so we find it more feasible for parents to come in the evening. That's one. And then our intervention is less intensive. We have 5 unique classes that we deliver over probably a 10-week span. And so it's not like, twice a week for an hour each time with a parent. We just know that for our parents that would be a lot of time sacrifice for them and away from work, etc. So we kind of de-intensified the intervention in a way to help it be a little bit more feasible for our parents.
Also, we are flexible, give them a sample and move on to the next one.
Right, it's not like you start on day one and everyone has to go through the curriculum at the same time. It's a rolling thing. It's more open, kind of.
Yeah. We try to, for example, if the family says, well, I'm interested in attending these groups, but I don't think I can do this until the summer time. Say, okay, well, why don't we see you back for a few individual visits, and then you can start group whenever you can, and just try to tailor what we're offering to what's possible for families.
In your practice, do you employ long-term care follow-up?
So we do try to follow the patients for as long as we need until we get at least at a minimum, BMI stabilization and improvement in whatever the child's comorbidities are. So if they haven't, elevated transaminases, which is something you see with non-alcoholic steatohepatitis, so essentially fatty liver, or if they have elevated blood pressure, or if they're pre-diabetic, which many of them are. So we try to follow them until we get improvement with that, and then sort of slow down the follow-up after that. And then it just really depends on their PMD, comfortability with continuing to follow, and then what the parent prefers. Some parents feel like, oh, I'd rather go back to my PMD to follow this, and some would rather follow their primary doctor, and some would rather follow with us. So we're flexible. As people are doing well, we tend to space out their visits, and then sometimes that doesn't go well, and then we need to start seeing them more frequently. But.
And also, I'm more available. I'm 24 days a week. They don't always follow up with me. And sometimes the primary care providers send them, they send them to me to follow up.
Yeah,
after healthy lifestyle.
Because we're only, right now our clinic is only on Mondays. So if the family is unable to come on Mondays, but can come on Thursdays, then, they can follow up more of the time. Okay, sorry.
What are the key risk factors for obesity that you see in your population? And how do those risk factors manifest themselves?
Well, so we treat kids who get their primary care in the Department of Public Health. And so all of our families are publicly insured or uninsured and technically, and they come from backgrounds of poverty. And so I think that in and of itself is a huge risk factor. They almost uniformly come from families that are also struggling with obesity, so strong family history of obesity. And then things like food insecurity would be a big risk factor in our population as well, and lack of physical activity opportunities that other children have.
Yeah, and I think also oftentimes parents come in with fairly low knowledge about healthy eating and are fairly surprised by a lot of our recommendations. So we tend to have a lot of low-hanging fruit after we do our intake survey in terms of changes that we can recommend to families and that can make a very big difference in how their child is doing. So, for example, we have a very extensive survey about beverages consumed, and we go through just a checklist of how many servings of each of these beverages the child has consumed in the previous 7 days. I think there's like 11 or 12 different categories, so it's very granular. So, and I would say on average, kids are consuming at least one sweet beverage a day, and many of them, it's more like 14 or 15 in 2 weeks. And I've seen as high as 30 in 1 week. So, so we often have a lot of kind of, in terms of diet, I think sort of fairly easier changes to make. Physical activity, I think, is much more challenging, mostly because of access.
I'd love to hear from Pauline about some of the dietary recommendations.
Yes, so as Sarah mentioned, we see mostly low-income families, and it is difficult to provide nutrition counseling for low-income families because healthy food is expensive. Just as Dr. Jackson mentioned earlier, the Farm Bill supports mostly big farmers, wheat, soy, and corn industry. So it is difficult to eat healthy. So that's my biggest challenge, asking them to eat healthy when they cannot afford it.
I see additional risk factors include a fair percentage of our patients have maybe two-parent situations, either parents are separated, and so they have one set of rules of eating and exercise in one family, and then a totally different set of expectations in the other family. Or other adult caretakers of the children that are not the parents, or the grandparents or aunts or something like that, which may not be on board with healthier eating. And then also, a lot of our parents work so much that often their kids are in after-school programs, and the quality of the after-school programs really vary, and sometimes the kids are really quite sedentary at these after-school programs with very little physical activity, but they get snacks, and then by the time they come home at 6 or 7 o'clock, there's very little time to do like after school sports. They're going to eat dinner, do homework, and go to bed. And so those are additional challenges that we specifically see in our population.
I'm interested in how you frame the issue to parents. So talking to them about behavior change without triggering paralysis or making it seem like something that is so big a deal that they can't overcome it.
Well, I think we try not to fix everything at once because that is overwhelming, and we try to find out what parents are interested in changing first and what they think is, most feasible for them. And we try to let that come from them. Sometimes, give them a few different ideas and say, which of these do you think you could work on? And or starting with, okay, a lot of times parents have a fair amount of insight into what the problem is when they come into the clinic. So sometimes we don't even need to make any suggestions. We just say, hey, what do you think that you could work on? And sometimes just having filled out the survey for parents has given them a little bit of pause, and they'll say, oh, I didn't even think about the fact that we have like a junk food checklist in addition to the sugar sweetened beverage checklist, and we have a place where they fill in how much physical activity the child has done and how much screen time they've had. And I think just going through that process, they can often come up with goals themselves, and I think that makes it easier because they can come up with something that they feel is achievable. I think we try to frame everything in terms of health. We don't talk about a weight loss goal. We talk about prevention of diabetes. Unfortunately, many kids come in already with abnormal labs. A lot of them have something called acanthosis nigricans, which is a darkening of the skin on the back of the neck, which is a sign of early insulin resistance. So we can usually point to those things to explain why we're concerned for the child's health, and I think people find that motivating.
Yeah, I mean, essentially we do a lot of motivational interviewing. We use those kinds of techniques and set things like the SMART goal, something that's small, realistic, attainable, that the patient and the family basically owns and feels like they can accomplish, small steps.
And also, we always put emphasis on health. So when the parents see the labs, for example, for children who have pre-diabetes, they're motivated to make changes.
Because often we'll see normalization of laboratory tests before we see any real significant weight loss, for example. Yeah.
Especially for fatty liver.
And how do you sort of get the whole family on board or engage parents, siblings, etc.?
I think it's hard. I think we always invite everyone to come to the group education and to any individual visits, and we always encourage parents to bring other members of the family, but that happens pretty rarely, mostly because of people's other caregiving and work responsibilities. And so what we try to do is to give the parents as much information as we can, so that they can be empowered to educate other members of the family, and try to use both the individual visits and also the groups as really like skill building exercises. So we do a lot of menu planning, we do label reading, we talk about the risks of different behaviors, and try to arm people with a lot of information so that they're not just going home and saying, the doctor said that we can't buy this anymore. It's like, the doctor said we can't buy this anymore, and here's the reason why, and here are what the concerns are. And of course, there's varying levels of success. So sometimes it's just a kind of ongoing process, and just depends. It also depends on what the communication is like between the family members. So particularly when parents are separated, that I find the most challenging to deal with. And when you're only seeing one parent, the child's only spending half of their time with them.
But I find that is the big challenge, especially if you have adults in the household who say, I just can't give up the soda and I'm not going to stop buying it, or grandma's not going to stop buying it, that predicts a lot for success, I think, for the child. And so I definitely tell my families that in order for the child to make any healthy changes, everyone has to make the healthy changes in the family, even if they may have a non-obese sibling. You can't have different rules in the household for different members of the family.
So, and I think the classes involve the whole family, because the mothers usually come. Sometimes the fathers come too, but usually the mothers come, and we exercise together, all of us, and as a group, and we ask them to do the same at home.
How do you handle a situation where a family or a child isn't making progress?
I think we try to diagnose the problem, being physicians, we're like, okay, what is going on here, and try to see if we can get to the root of it, or if the family can get to the root of it, if they develop some insight into it. And I think the other thing is that sometimes we just try to keep bringing people back and encouraging them. We do see a lot of yo-yoing, so we see kids who lose weight, they gain it back, lose weight and gain it back. But then if you look over a year, oh, you're actually, you know, in the same spot, which is good because children are growing, and so if they actually had net zero gain, and starting off obese, if you have net zero gain over a year, that's actually a good thing. So I think just continued follow-up and kind of letting them know that we're not giving up on them despite whatever challenges that they're having.
I mean, treating obesity, like a lot of chronic diseases, is not like, you know, solving an infection, like you get antibiotics for a week and then all of a sudden they're better for life, or, you know, they don't have that one particular infection anymore. It's an ongoing struggle. And so we are actually not super dismayed if, you know, if there's not a whole lot of progress. We just keep seeing them, keep having them come back, keep repeating the messages, keep being their partners in this, because we know it's difficult, and really trying to be that positive presence.
I usually try to find out what the problem is. For example, if the mother has 2 jobs, she doesn't have time to cook. I try to find easy, healthy recipes for the mother, and sometimes the family eats out a lot, and I just have to teach them how to choose healthy when you eat out. I just try to solve the problem that's keeping them from being healthy and losing weight.
Pauline, you also identified cost of healthy food as a barrier. What kinds of strategies or tips do you give patients to deal with that?
Yes, so we have several farmers market in the city, and I've been to almost all of them, and I know the prices, I know which ones are cheaper, and I tell them what to buy and where to go. Unfortunately, we have food deserts. Some areas do not have farmers market at all, so I try to find out how to get to the farmers market by bus. And also, most of our families go to Costco to shop, or Safeway. And I've been telling them to go, for example, to Trader Joe's, because I know that an item is cheaper at Trader Joe's than at Safeway, for example. So that's how I try to help.
Have you found patterns in children or families who are able to lose and maintain a healthy weight?
Well, I think an important thing is that parents recognize the problem and have some insight as to what's going on in their family that's contributing to it. And then it's usually when they're willing to do whole family change. So basically keeping the home as a no soda zone, no sweetened beverage zone, no junk food zone, and, you know, committing to either, you know, physical activity together as a family, or supporting their child and participating in some form of physical activity. So when kind of everyone gets on board with it, then we see the most success.
I would echo that. Like, the whole family is invested in the change. They see it as a very serious thing that they want to commit to, and they're more unwavering in the changes. Less likely to make exceptions for this, you know, for this occasion and that occasion, to kind of, you know, eat more junk food or drink more sugar beverages. They're much more consistent with the behavior change.
Yes, and sometimes when they come to see me, I tell the child not to stop drinking soda, and the child tells the mother, but you drink soda. So if the mother doesn't stop, if the parents don't stop drinking soda, the child, it's not possible to stop it.
I will open it up to questions from the audience at this point. Oh.
Oh, sure. Just she just was wondering if we could offer a copy of our survey. Yeah, just email me. I don't know if my email is available, but amy.beck@ucsf.edu.
She's on Google.
Yeah. We do not tend to attempt that. I think, most of our patients are children, and so they're not necessarily that responsible. I can imagine it may be working better with some of the older teens. What we use more is kind of recall over a week. So, we ask about different beverages consumed in the previous week. We ask about fruits and vegetables. We ask about junk food. We have it very granular. How many bags of chips? How many, times did you eat cookies? All these various things. Whole grains. We ask about white rice and tortillas and pasta and all those things. And it's a recall over a week, which is kind of a snapshot. But are you saying like writing down everything?
Like diaries?
Yeah. Yeah, we haven't done a lot of that. I do think that there's some literature that shows that in and of itself it's beneficial because it increases your awareness. I think that all of that is adult literature. I'm not aware of any pediatric literature that has used that approach, but I could be wrong.
So we tried that for some of our patients with diabetes. It actually didn't work because sometimes they came with empty pages.
I haven't had success with failure to thrive patients doing that, but.
Hi, I just want to say thank you for coming and speaking about your experiences. I was just curious, what kind of outcomes or indicators are you guys tracking over time to find out what's working, or whether certain types of group education sessions are more effective than others, or other types of interventions? I was just curious about that.
So we do have a grant right now to do an overall combined quantitative and qualitative evaluation of the group education sessions, and so it's not finished yet. We're still collecting data through the fall, but essentially we're looking at reach. So we're looking at the number of patients referred to us who actually comes to our intake. Of those who come to our intake, who starts coming to group, how many groups do they attend, and then what are their outcomes in terms of their BMI change over time, and then changes in a number of different dietary intake values, and then also their laboratory values. So we don't have that data yet, but next year we will.
Hi, thank you guys for coming. My name is Emily. I'm an AmeriCorps member, and I do health coaching for pediatric kids who are overweight and obese. And so this is kind of a random question, but something I've heard about that's can happen, it's very tragic, where obese patients, they end up developing eating disorders because of the pressure put on them by their families and the providers. So I'm wondering, what specific language do you use to help support positive body images, but also show them that they do have a serious health problem? So what's the specific language you use?
Well, I mean, I never use the term obese. I don't really even use the term overweight. There was like an interesting qualitative study that was done in Colorado where they asked parents what terms they preferred, and people liked the term weight is too high for health or for optimal health. So that's what I try to say. And then we do focus in the group education on how parents should talk about weight. And basically our message is that they shouldn't talk about weight, they should talk about health. So framing everything. So if you're telling your child, oh, sorry, we're not going to buy ice cream today because we have made a goal to only have ice cream once a week. It's not, we're not going to buy ice cream because that is fattening. It's, we're not going to buy ice cream because we know that ice cream is not a healthy snack and we want you to be healthy. So yeah, I think those are the two biggest things. And obviously for parents who don't attend group, if I overhear, I try to model for the parents the discussion, and when I overhear the parents talking about, the child's weight, or making a comment like, now I have to buy him all new pants because his pants are, too tight, or, I couldn't even find a dress for her graduation, etc. Then I try to gently pull the parent aside, or, in the moment, try to kind of remind them or encourage them to reframe the issues so that there's not a big weight focus in the discussion. But it's a concern. I mean, I am very concerned about that. You haven't seen that yet, but it definitely worries me.
I'd say we haven't seen the classic eating disorders like anorexia nervosa or bulimia develop in our children, but when we do survey them in the beginning, we ask about emotional eating, and a lot of them do not eat purely out of hunger. A lot of them will say, yes, I eat out of boredom, out of stress, out of, so there is an emotional component to eating, whether or not they have like a frank DSM for eating disorder. So it's present before they even arrive through our doors.
Hi, I'm Marcella. I'm with the YMCA of San Francisco. Sorry. And I think a common theme of this whole day is about accessibility and where grocery stores are and farmers markets and how we make that available to people in the community. And so in our organization, we just teamed up with CalFresh. And I was wondering if you guys are aware of that agency or if you work with family resource centers. I know that you spoke to doing kind of the work for your families and looking at Costco compared to Trader Joe's, but are you working with other agencies to really help these families have access to farmers markets and know where to shop and who can kind of help them in their neighborhood?
Yes, we have CalFresh handouts. I have them in my office, and the whole hospital has CalFresh handouts, and then we have WIC in the hospital, so they can always go there. And also we have a matching program for the farmers market. So if you spend $10 buying vegetables, you get another additional $10. So we also have that program. And also we have a lot of food pantries in the city.
Hello, just to kind of piggyback off of that, I did want to share, I'm from the food bank, the SF Marin Food Bank, so I definitely wanted to put this resource out there that you can definitely share this with your clients, access to free pantries within both San Francisco and Marin. So I would say taking advantage of that as well, in addition to other items that can be purchased at grocery stores would be wonderful.
Thank you.
You mentioned that you, in the group classes, you have about 5. Can you share with us what topics you specifically focus on? I think one was sugary beverages, one was physical activity.
No.
She teaches all the classes, so she knows them like.
So each class has a nutrition topic, except for the last one, which is about physical activity and screen time, and then kind of a parenting topic related. So the first class is basically all about beverages, and then for the parenting topic, we talk about like Ellen Slaughter's division of responsibility, and then group 2, we focus on My Plate and menu planning, and then the parenting topic is actually this exact question of that you mentioned of how to talk about weight in the family, and then the third class, we talk about healthy breakfast and healthy snacks, so kind of including protein in your breakfast, and then we recommend snacks that are pairing a fruit and vegetable with some form of protein and avoiding grains for snacks. And then the parenting topic is about kind of positive reinforcement and how to sort of talk about these issues in positive terms. Group 4 is about hidden sugars. So things like yogurt, everyone's very surprised that a Yoplait has 27 grams of sugar, which is the same as 8 ounces of Coke, and hidden sugars in cereals. And then also selecting how to select whole grains and how to find higher fiber foods. And then the parenting topic is about kind of limit setting and ways to set limits in a positive way. And then group 5 is about physical activity and screen time, and then the parenting topic is about role modeling. So those are the 5. We try to cram a lot in.
And in addition to that, they have a private session with me for 45 minutes to emphasize that and to add on.
Yeah, so everything gets reinforced when they have their nutrition visits, and then we also try to reinforce when we have their one-on-one visits with one of us or our nurse practitioner.
Hi, I'm over here. Hi. So I work for an organization that does do a similar model of 6-week intervention group classes. But I'm also speaking as a parent, in that I practice all these things in my home, and my biggest challenge is the environment, and my children go to public school, and though our district has a wellness policy, and my child goes to a school with very well-educated parents, it is appalling what my children are exposed to on a daily basis. And so my hands feel tied, and I'm an educated person. And working with families, I can see how even if they did everything right, the environment that they have to send their kids to, even just school, is so difficult and challenging and doesn't reinforce a lot of the things you want. So I just really want to encourage people in the room to start advocating for the district wellness policy and lending some more push behind it, because it's met with a lot of resistance. But my other question was, as physicians, and our organization is working with San Francisco General on developing some kind of tools for some of the residents to start having these discussions about food and diet with their patients. But as a physician, what do you think is the most effective way for physicians, if there is an effective way for physicians to talk about this to their patients in the 10 or 15 minutes that they may have with them?
You mean how to do better at school? You mean like?
Oh, sorry, just about food and sort of personal behavior change.
In the context of, is your question like in the context of a primary care visit? We're lucky since we're an obesity clinic. We spend an hour with people, and but yeah. So that's kind of my research area is primary prevention of obesity and primary care, and it's extremely challenging because you have so little time. But I think you can also employ surveys in primary care as well. So having the patient spend a little bit of time before you get in the room filling out some information can be really helpful, so that at least your counseling can be focused on something that's an issue. If you walk in and say, well, we're really worried about sugar sweetened beverages and kids are drinking too much and the child hasn't had a sugar sweetened beverage in a month, and their problem is their 8 hours of screen time a day, then you kind of wasted your time. And so I think trying to employ those surveys so that you can make the time worthwhile, and then trying to focus in on what is motivating to the family. And then I think in pediatrics there's so many kind of dual endpoint messages. So if parents are not particularly concerned about obesity, whether or not that they should be, when parents come to us in obesity clinic, to a certain degree they're concerned or they wouldn't have come to the visit. They're at least open to hearing about it. In primary care, they really may not be interested at all, but maybe they are interested in dental caries because their other child had to have dental surgery, and a big thing that was driving it was the sugar sweetened beverages. And maybe they're not concerned about obesity, but they're concerned about screen time affecting their child's sleep quality and then their child's academic performance in school. And so I think trying to see what they're worried about for their child, and then where you can fit in messages that have those dual endpoints. So we know that physical activity has many other benefits beyond weight maintenance and weight reduction, for behavior, for concentration, the same for screen time, etc. But it's very challenging, and I don't personally think that primary care, the doctor encounter is enough. I think that we also need the presence of health educators and health coaches and a lot of other ancillary support to really make primary care settings kind of conducive to really good obesity prevention. But I do think that the doctor can, lend some kind of gravity to whatever it is that their message is. If that helps.
And I wanted to add that I'm always available, and the providers, they come and get me. They see the patients for 10, 15 minutes, and then they call me, and I go to the exam room to talk to them. So
yeah, we're lucky because we have Pauline, but not everyone has the easy access. Yeah.
We have time for one more question.
Hi, I'm actually a pediatrician in private practice, solo practice, and I graduated from UCSF, and I must admit, some of the things that I did not get were, how should I say it, teaching on nutrition. And so I've had to do a lot of study on my own, and I actually do a lot of nutritional counseling in my practice. So when a patient comes in with labs that are not too good, parents are really concerned when they see bad labs. And so I actually spend an hour with each parent or whoever the caregiver is, and go and talk to them about the nutrition. And I start them very early. So my question is, I can send patients to you guys because you intervene, but the area of prevention is really, to me, is just very lacking in general. And so I'm looking for resources in the community. Like I became a master gardener, I'm learning how to cook, I would like go to chef school so that I can actually teach them. So some of the things that I've done is that I made some videos to teach my patients, on YouTube. I made like 18 videos. It was so much fun just doing the research. And I do demos in my office. It's just so much fun. So hopefully someday we would like to see a kitchen in every hospital, every school, and every, perhaps, I don't know, building, medical building. So we got to do something. It's very exciting to me. So anyway, that's my input.
Sounds like you're doing really great work.
Yeah, I
and
wanna
you're
see your
having a
videos.
lot
That
of fun
sounds
doing
amazing.
that. Yeah, that's good.
Yeah.
We do have cooking classes, general. Yeah, we have a wellness center with cooking classes, and every clinic has a dietitian. So the students really walk around it.
You know, Cooking Matters. I don't know if anyone is here from Cooking Matters, but they, and I know that one of our receptionists was telling me about her amazing experience going to Cooking Matters classes with her daughter, and so I've been trying to get our patients to go. Again, it's always time, opportunity costs for people who are working multiple jobs and are very stressed, but I do think that there are some great resources for teaching cooking.
All right, well, thank you three so much for being here and sharing with us your experiences.